Hi, this is Sophia, the Associate Executive Producer here at the Docs with Disabilities podcast. Before we jump into this episode, I wanted to take a moment to announce that we are now conducting an open call for stories to be featured in an upcoming multi-episode series on disability disclosure. The series will highlight the multitude of factors that impact whether or not individuals decide to disclose, we'll discuss what happens after disclosure, and will hopefully generate knowledge about how to create safe and welcoming spaces that support disclosure. If you are a health professional student or clinician with a story about disclosing or choosing not to disclose a disability, we would love to hear from you. We think that stories from you, our audience, are such an important and powerful way to talk about these ideas, and we really hope that you'll consider getting involved. Anonymous submissions are welcome, and you can share your story in an audio or written form. More details can be found at DocsWithDisabilities.org/podcast. The deadline for story submission is June 15th. Disclosure is such an important topic, and we are grateful to be able to explore it together. Now, back to today's episode.
Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession. Welcome to part 2 of episode 67. If you have not yet listened to part 1, we encourage you to rewind and engage in that episode first. Here, in part 2, we pick up where we left off with Doctors Green and Jain discussing the delicate distinction between the risk of stigma versus the reward of accommodation and inclusion, and how people navigating the decision to disclose disability and request accommodation face a multitude of barriers.
That's a really kind of delicate distinction, isn't it? That idea between stigma being so strong that people don't want to be labeled, but then that being a barrier to organizing or connecting or getting the information that you need. And when I was a disability resource professional and I worked with med students, often they would tell me stories and they would kind of in some way convey that they felt like they were the only one who had experienced what they were experiencing, or that, it might sound strange, but this is what I'm experiencing. And I would always try to kind of highlight that you're not the only one. I hear this from students all the time. This is common. And that feeling of being the only one both was a barrier to being out with others, but also sometimes held them back from even asking for things in terms of accommodations or supports. And so that kind of helping them to understand that what they're experiencing is really typical was really powerful. But also, there was like a hunger for connection, but a simultaneous hesitation because of that stigma. And so it's really interesting to hear what you're talking about creating channels that could be perhaps more anonymous or more private, creating spaces where it's really clear that this space is just for us, for disabled students, to have an in-group space where we can talk about things, even though we appreciate allies and accomplices, we need these spaces just for us. And thinking about how to do that organizing or support work that you've done with that kind of sensitivity, I think is a really interesting model.
So we had a lot of great conversations about that, because even just kind of going back to what you said earlier, so I'm sure that you understand this, but a lot of people don't understand this. So it's like, okay, well, then why don't you just get accommodations? So let's say that we're all taking a test today, and you say, "Where's Emily?" And you see me later, and you're like, "Why didn't you go to the test?" So either I'm like, "Oh my God, I was gravely ill and now I'm fine," or I have to say, "I did take the test, but I took it in a different area because I have accommodations." That in and of itself, just getting the accommodations, especially in a place like medicine where we're supposed to be perfect and we're supposed to be like super smart and we don't make any mistakes and everybody is an A student, like that's so not true. But there's still that thought that like disability cannot equal doctor. Like there's somehow that doesn't work, and that's not true because disability really just means that you do something differently. I just want every person that I work with to have a dream and for us to work as much as we can towards that. And for me to never say, you can't actually do that because of A, B, and C. I'd rather it be, this is what you want to do. Let's see how far we can go. But I cannot do that without you having the information. And so I want everybody to be able to easily get accommodations. It's really not that big of a deal. I don't like that there are people that are not doctors because they needed 30 seconds extra on a multiple choice exam. That doesn't make sense. They're amazing people and they would have been amazing doctors, but because they didn't get accommodations, they didn't pass step, they had to leave. I just find that to be ridiculous and it makes no sense. So that's actually what I'm working towards in terms of my like goals like for life, is that I actually do want to change policy on ADA accommodations for national exams because I feel like it's just the cost alone for like neuropsych testing, the information that you have to know, the know-how that you have to have in order to get through that, I think is just absolutely ridiculous. And at the core, it's really just about what your doctor says. And I just wish that they would actually go by that. Where it's like, if you got the testing, this many years ago, like I'm sure that most people don't know that you have to get it within 3 years, even for STEP. And that's a huge deterrent because that means that you have to do it for the MCAT, you have to do it for STEP, then you have to do it for board. Like that's thousands and thousands of dollars getting added up just for this one small piece. So even talking to people about time changes in terms of the years in between that it can be for neuropsych testing is something that I really want to bring to the table, where it's just like, is there actual information stating that if I was dyslexic and ADHD at 7 and it still says it when I was 30, can we at least put like a 10-year gap on this? Because if IQ is really supposed to be stable, as long as there's no kind of TBI or some kind of other issue that happens with your body, then can we trust it for longer than 3 years? Can you trust it? Because it's a huge thing that stops a lot of people from getting to where they need to go.
Yeah, that financial piece, the time piece, to get the reevaluation. Are there other kind of factors that you've seen in the kind of advocacy work that you've done that create barriers to getting the documentation, to making the request on step one?
So something that came up, and this was in med school, like during one of our meetings, was international students. So they don't have 504 plans and IEP plans all around the entire world that look just like ours. Or someone literally left their country. They cannot go back and get those records. What does that mean for them? If you're saying that there has to be some kind of documentation, or they have to get a letter from a school that doesn't exist anymore, I hate that that's something that could just stop somebody in their tracks. But we don't think a lot about the international students and how we are, especially in a special education, we are taught that this is the way that we do it in the U.S. And so it's really difficult for people who are outside the U.S. to get that kind of paperwork. And if they do, it's still going to look different. And so it's going to be questioned.
And you mentioned that you're still doing work with Black and Latinx students from your school. Can you talk a little bit about that?
So it was actually collaboration. So it was Students with Disabilities, it was also the Black Student Organization and the Latinx Student Organization all came together, and they had me talk about what it looks like to be disabled and be a resident, to do that through med school, to have a kid in med school, to be Black in med school. I just kind of talked to them and, of course, gave my information so that anybody who had follow-up questions could ask me on their own. But that's what I did. That was a couple of months ago. I will say that the institution that I'm at right now, also, they just had a better handle on a lot of the STEP stuff, which was great. But we're still talking about just everyday cultural, everyday clinic stuff that still comes up with having a disability. I think that testing is very safe in terms of people understand if you have a disability, you should get extra time and you should get this. When you're talking about notes, when you're talking about looking things up in a certain amount of time, when you're talking about having to write out things for rounds, then things get very, very messy. And talking to students about how you can advocate for what you need, because everybody's going to be different when it comes to that clinical setting. There's just no person that's the same just because they even have the same disability. So that part has been really big in terms of I feel like my role has changed where now I'm talking to certain students about actual clinic accommodations, because that's where it gets really confusing.
That is, I think, the realm that people struggle the most with, anticipating what they need, and then also schools and programs really feeling comfortable, maybe is the term, saying that those accommodations are right. So talk a little bit about accommodations in clinical settings and what experiences that have you had with that?
Yeah, so I think that one place where we don't do great is that for testing, people have been tested since they were in kindergarten, right? So it's like Emily needs a separate space and she needs it to be distraction free and she needs time and a half. And everybody, all throughout med school can do that. They're like, yeah, I can totally do that. But then when you're talking about what does Emily need in order to do a note in time, then it gets really confusing, because then it's like, well, first of all, I've heard this a lot from med students, like, well, what are the accommodations that are available? Because you've never heard of it. You've never been in a clinical setting. So actually was recently talking with someone about that. So things like noise canceling headphones, getting extra time to do notes, having a way for you to take a break, even things, this is something that I needed, like lined paper for rounds, where it's like, I can't have just, my handwriting is so terrible. I literally don't write straight without lines. And so there are certain things that I needed that no one would ever think about. It was a very unique situation for just me. But by me sharing what accommodations I got, it helped other students to think about what is possible and what they might need. So it's like talking about, do you need a chair because you have a back condition? Do you need to have scheduled breaks because you have diabetes and you have to be able to go and get a drink? You have to be able to go to the cafeteria and get a juice. Things where it's just like, what do you think you might need just based off of what has happened in your past? But especially when people are coming in here and they've never had accommodations before, maybe they were diagnosed at a later age with anything, it's really helpful then to have that group setting, because then you have people that have had that issue for much longer and they can say, this is what you should ask for, or these are the certain things that you can get, and these are the certain things that you cannot get. And so I think that that's been the biggest issue for a lot of medical students, is they're just like, I know I need accommodations. I have no idea what I need though. I just know that what people are doing standard is not going to work for me, but I don't know how to work around it. And that's where the group perspective is really helpful, because you have fourth years, you have third years, you have other people that are saying, this is what I needed, or this is what I used, or you have residents who can say, this is what you can have in surgery. Like, what kind of If you have diabetes and you're in a surgery that's 4.5 hours, you want to be able to talk to somebody else and say, so what did you do and what does this look like? That information is so important. And it's very unique, but at the same time, you can at least get information from others.
Yeah. So that kind of crowdsourcing, but you said something that I think is also really important, which is that idea of like you sharing the kinds of accommodations that have worked for you, even if they're not the same ones that someone else will need, it starts to spark that thing of, oh, okay, I could ask for those kinds of things, or maybe I could ask for this thing that I didn't know if I could speak aloud or whatever, that it opens up people's kind of the realm of possibility of what could happen. If it's someone who has a very similar experience, that's even better. But, even just speaking it aloud, I think, or sharing is possibility expanding almost.
Yeah, bells go off. People are like, oh, right, I could do this or I can do that. But it's really difficult to do that in a vacuum. So having the student support, having, your peer support is really important, because it helps you to kind of figure out what do I can't do time and a half on surgery. So what can I do? What does this look like? And a lot of times, especially for like learning disabilities, it's really about the paperwork. I remind people, like, nobody's asking for time and a half on CPR. That person's going to die. Like it is a reasonable accommodation to say, but afterwards, when I'm looking this up or things like that, I need to put on headphones because I'm in the ER and I'm going to get distracted. And so I have very bulky headphones that everybody can see, so that somebody can put their hand in front of me and say, I'm trying to get in touch with you. Or I have my pager on vibrate so that I can still feel that, but I'm not being distracted by another screen. It's just these kinds of workarounds that really, when you say them out loud, it's like, it's not actually that big of a deal. People, they know what you need. I think that people that apply for medical school, who get into medical school, who do these things, they know what they need to do. It's really just little tweaks. But in order to do that, you kind of need to know what tweaks have worked in the past. What do you actually need? What have other people needed, and what can be provided? Because certain things can't be provided. And you want to know that. You can't have a half an hour break, but I can give you a 5-minute break every 30 minutes. So just having that conversation.
Yeah, I think that can be so powerful in a space that's so, what you talked about, that kind of unspeakable space of stigma and disability, is how stigmatized disability is, makes the act of asking for accommodations, like brainstorming what you need, feel dangerous. And so just to be able to have a connection with someone, or to even hear what has worked for other people, what's possible, it's that kind of bells going off, I think, is what you said, that it's like, okay, yeah, things are possible. And moving beyond that kind of cookie cutter, like time and a half, to think about other kind of tweaks that could be made in an environment to make it more accessible.
Because that's the really confusing part, is that people ask for you to ask for accommodations beforehand. So they say, tell me what you need and we'll put this down. And you're like, I don't know what I need. I've never done it before. That's where I think a lot of the kind of that confusion comes in, where it's like, I don't know what I'm asking for because I've never done this before. I don't know what I need. And that's where it's like, you really do need that peer support to figure out, like, what do I need? What should I be looking into? And you want to be able to talk to somebody else with a disability to say, what did this look like for you? So I could tell people I didn't actually need to use my accommodations in a lot of settings, except in emergency OB-GYN, because they needed their notes really, really quickly, because there were always patients, coming in literally in labor. And I had to just kind of like invoke my rights and be like, okay, actually, I need it to be that my patients are a little bit more spread out because it's going to take me a little bit longer to do the paperwork. And they were totally fine with it. You're in a group setting, but I didn't know that I really needed that until it happened. But thank God I said, I need just, going off of my testing, I was like, I need time and a half, whatever that means to whoever it is, for notes. It's weird and it doesn't quite make sense because you're like, what is time and a half? I don't know. Whatever time you think that I was supposed to have, can I have a half more of that? It's just, you just roll with it.
Yeah, it's kind of a shortcut when you're not sure. You can at least lean on that kind of framework to say, okay, that's where maybe time and a half fits in. So, can we talk a little bit about residency and kind of the transition to residency and how that might have been different or any new challenges that you faced in residency?
So when I started my residency program, they offered me extra time to study for STEP just because they knew that I had accommodations before, and they were just offering this to me where it's just like, what do you need, Emily, for this testing? And it was really great. Where we really hit a wall was, again, in the clinical setting. So, your intern year, it's almost all in the hospital. You're doing a lot of things very quickly. You get into a flow of things, and then you're thrown into outpatient. And outpatient is actually sometimes even more chaotic. So we have things like My Chart, where patients can message you at all times of day on any day. And you have to get back in a certain amount of hours. And then on top of that, you might be on consults in the hospital. So you have somebody who isn't there for your primary reason. So it's not for psych, but they're acting out in a psychiatric way. So I have somebody hallucinating, but they also just had brain surgery. So I'm trying to figure all of that out. But I'm also, holding the pager, but I'm also doing this. And it's like, oh my God. So I actually didn't get accommodations until this year because the outpatient along with the inpatient was really difficult to juggle with my ADHD and dyslexia, especially the first time having to do paperwork for somebody for disability, like literally doing FMLA paperwork. That took me a lot longer than probably for most people. There are certain things that I have to read over several times, and getting those accommodations were much more difficult because, again, it's one of those uncharted territories. I don't know what it looks like for me to do FMLA paperwork for somebody. I don't know what it looks like to help somebody to get accommodations on this side as a psychiatrist. And so I think that they have been very open to it, but that was much more difficult. Again, doing testing is so much more straightforward than clinical work. And your clinic work can change from first year to second year. And for me, it was really actually third year where it was like, okay, we need to figure something out because right now what we're doing isn't working. And I hate to say that it was reactive, but it's just like, you don't know what internship is going to look like compared to second year, compared to third, compared to fourth until you actually do it. And so again, I would say, like, if I did have, that kind of group that we had in med school, that would have been very helpful. Residency, of course, is much more difficult in terms of your schedule is insane. You don't have a lot of time to be just kind of talking with other people, advocating, doing these things for just yourself. And then on top of that, it's much smaller. So, you're in a class of 10. So in order for you to actually get a good group, you'd have to coordinate with neurology, and you have to coordinate with radiology, and you have to coordinate with internal medicine so that you can actually get enough people that it makes sense. So I think that institutions are still trying to figure out how we can advocate for disability when you're not technically in school. Because residency, even though it's a part of school, this is your job. And a lot of jobs don't have disability resource centers for your job. Like, that you're not going to find that at McDonald's. It's a very different kind of setting. And so I think that that's something that we still need to work on, is how do you support the residents who are, this is actually their job, and so that they don't feel also kind of that alienation of like, I'm the only person that actually needs accommodations in this clinical setting outside of school, because that's really hard.
Yeah, so it's once again that feeling of being the only one, and not having that network, and not having even maybe a person within the institution who's talking to a bunch of people who can fill in the gaps for you or connect you with other people. So if you were to kind of imagine a better or an ideal kind of support system or structure of support within residency, what would that include?
I think it would be someone who's not a part of GME, because that just makes people nervous, but someone who's possibly like a part of the institution at large, but is not, involved in anything with your paycheck, or something that makes you feel kind of uncomfortable. So possibly like a tenured faculty member, someone that, but also somebody that would, of course, be disabled. I don't think that you can have an able-bodied person be in charge of that, because so, it gets more sensitive as you go up the ladder. So, undergrad was a different beast than this one, and it becomes more complicated. Just like I said, I still have that thought in the back of my head of, is my patient questioning me because I was openly, because, so in the back of my head, I'm having, is this patient questioning me because I told them, like, yeah, I have ADHD as well, and I understand where you're coming from, and now they might think that I'm lesser than. This is your job. You don't want it to be questioned. And then, it's also about board certification. They ask about those things, about some states ask about psychiatric illness, and are you going to put learning disability as an illness? And if you do have a learning disability, there's a really high chance that you also have some kind of depression or anxiety. Unfortunately, that's just statistically speaking. So how much do you disclose? So it has to be someone that people would actually feel comfortable with. And it would need to be somebody that's going to be consistently there. You don't want it to be a resident, because residency ends. So you'd want it to be a faculty member. And I think that it would be something that would come out in an email to everyone, but specifically stating, if you as a first year intern or whatever, if you've had disabilities, you've had accommodations in the past, please come to this meet and greet and we can talk about that, so that you have a place that's safe. But it's always going to be a leap of faith for anyone to come out and say, especially for an invisible disability, to, because every time that you're walking out there, you're outing yourself. It's a different kind of situation in residency. It's your job, and you get nervous about fellowship. You get nervous about, would the institution want to keep me if I have accommodations? So you'd want somebody that's tenured, that people trust, who can, and who also has some kind of disability, who can say, this is a safe space. Let's figure out how we can help you to be your best person.
I am curious what you love about being a doctor with a disability.
Especially being in psychiatry, I just love being able to look somebody in the eye and completely truthfully say, I know exactly what you're going through, and we're going to get through this together. The trust that I can get from a patient, from just being honest about that, about what I have to deal with. There's just this empathy that comes with it. When someone says something like, I hate this medication, or that neuropsych testing, I wanted to, one person, he was like, I was about to walk out. I was like, oh, well, I just cried my first time, because I remember doing it when I was at, age 11. I literally started crying in the middle of it. It's like, and people seeing that and seeing that they can trust you with those thoughts and those fears. I love being able to do that. But even more importantly, I love being able to give the information that I learned so that somebody else can be better. Like, I just don't believe that if I had to go through this, that you should as well. And I know that that's a really big thing in medical. school, in residency, where it's like, well, this is what you have to go through. What if it wasn't? What if it was that we actually made things easier for people? And so I just love working in psychiatry and actually helping somebody to have an easier time with the difficulty. I want everybody to embrace their disability, whether that be depression or bipolar disorder, schizophrenia, because I think that there is beauty in all of these things. But I think that in order for us to actually see that beauty, we have to take down that stigma where it's like, this is something beautiful. This is something that God has given that just this person understands. And I just love being able to see somebody flourish within it and to say, you have something that nobody else has, because it's just your experience and you can help somebody else. It just feels great to see people get better and know that a part of it was because they could connect with me on a level that they could not connect with others.
The power of that connection is something that you have really harnessed throughout your life and through your career. You've really activated how the interpersonal connection that's possible through disclosure, through sharing these stigmatized experiences have turned into like a superpower of connection and of belonging. I remember a student told me that disclosure was like opening a door and creating this beautiful connection that invited other people to share in deeper and more meaningful ways and connect through that. And I can see that really clearly in your work and what you've done. I'm curious what advice you would have, particularly for Black students or other students of color with disabilities who are either in medicine or aspiring to medicine. What advice do you have for them?
My biggest advice would be, I know it sucks and it's like, why are you saying this? But just embrace whatever you have. I think that when we don't embrace it, it takes over us in ways that we didn't understand. I missed out on a lot of opportunities because I didn't embrace it. So I was offered accommodations for like the ACT, for the GRE, and I didn't do them. And thankfully, it didn't mess me up too much with the ACT, although it was not great. And with the GRE, I just didn't get into the program that I wanted to, which was great because now I'm here. Because I would have gotten into, a PhD program. I didn't actually want to do that. Great. But at the same time, it was really stupid. And it was that thought that I'm already Black. I'm already a girl. I'm already, like, unfortunately set up to fail. And now you want me to put out disability as well. And it's so difficult because you want to have as few negative things against you on your record. You want to minimize it. But when you start seeing it as a positive, where it's like, I have a disability and I was able to do this. I have this disability and I was able to get all the way over here, and I know that I can only go further. It really will help you. I have to say this to a lot of my patients, unfortunately, like with schizophrenia, who aren't taking their medication. And I'm like, why aren't you taking it? Like, is it making you ill? He's like, no. Do you not like the side effects? Are you having side effects? He's like, actually, no, I'm not. Actually, my mind is a lot clearer. Why aren't you taking it? And it's the stigma behind it. He does not want to be schizophrenic. And he has every right to be upset about it. But the thing about it is that, unfortunately, this is where we are. These are the cards that you were dealt. So let's play them and let's do everything that we can in order to make it the best that it can be. So I'm not saying that you have to wear it on your shirt, but whatever kind of accommodation they're offering you, or whatever kind of thing that you think is going to help you out, whatever like extra program or tutoring, take advantage of it. Don't say, well, I'm not that disabled, so I don't need to. It's so much easier for you to take off than to put on later. Don't do the whole, I'm better than this, and so I don't need this, because it will envelop you. Instead, embrace it yourself, and you're the one that's actually steering the ship and saying, this is what I need, and advocate for yourself. because there's another little brown black kid that's watching you and who's going to remember that interaction. They really are. And they need to see us. They need to see us being doctors, being PAs, like doing these big jobs. They need to see that so that they know that they can also do it as well.
I think for me, super important that systems, programs, schools need to change. Individuals can do a lot. Students can do a lot to advocate, but what you've described to us is a lot of labor that you've taken on top of the really challenging work of training to be a medical student, doing residency. You're doing a huge amount of labor on the side to support other people, to shift systems. So if you had something that you'd like to tell medical school leaders, residency leaders, what would you like folks with a heck of a lot of power in medical education, in licensing spaces, what advice would you have for them? What can they do to improve things for docs with disabilities?
I think that this has been echoed in other podcasts earlier, but it's making it so much more visible, where it's like, make it easy for somebody to see who is the disability person, who is the GME person that does accommodations. I hate how much it's hidden. The more that you look for it, the more that you feel self-conscious about it, where it's just like, do I actually really need this? Because I've had to go through 6 different pages. My husband actually helped me with my accommodation stuff. And he was like, oh, dear God, do you know how long it took for me to get this one thing for you? And I was like, yeah, I do. That's why I asked if you could help me out. I was doing all this other work. I feel like they make the process so difficult. And I think that there's this fear that people who don't need accommodations are going to ask for them. I think that if you actually look at it, the accommodations that people are asking for are very small. Nobody's asking for a boat. They're not asking for their own private office that is padded so that there's no distractions. But I feel like people are always afraid to give somebody an extra step because they're going to somehow do something wrong with it. And I just wish that it would be much more open and trusting, that the person's going to use it in the right manner. I just feel like people with disabilities, especially learning disabilities, are not trusted, as though we're somehow going to try to get a leg up instead of just trying to be on level ground. So it just really be about, can you be more transparent about what you have for disabilities? And please be open to people asking for these things, because I really don't think that it's a big deal when we're asking for time and a half. Like, let the doctors in their testing and in their assessment believe them. Don't make us always have to somehow justify it as well. You wouldn't do that with somebody with hypertension. You wouldn't say, well, show me how, you get lightheaded when this happens, or, you wouldn't do that for any other issue. But for some reason with disabilities, especially learning disabilities, what the doctor says is somehow not enough. And they make us go through all these extra hoops. And it's like, can you just put all the information out there, make it very easy for us to find, and actually trust us when we say that this is a disability and this is what I need?
Yeah. That coming from a place of higher trust, I think, is something that really needs to change, because you've illustrated, the amount of work that's required to get the accommodations, and that's just unreasonable. The level of proof it's not warranted, as you say.
And I think that I think that people think that somehow they're going to be flooded with like accommodation requests. I don't really think that's going to happen. Sometimes, and this might sound counterintuitive, but sometimes just knowing that it's available helps people to feel calm enough that they may not even reach out for it. But just knowing that they have this safety net, like, be open and honest about what you have. I don't think that everybody is going to just be like rushing in to get all of these accommodations or things like that. Most people don't, including myself, like, I don't want to need this. Like, this isn't something where it's like, oh, I'm showing this out. Like I hate that I have to do this, but I have to do this. And so I need to embrace it, and I need to just be honest about it and say, this is what I need. But when somebody isn't like trusting of me and I have to write a whole paper on why I need accommodations instead of you just allowing me to send you what my doctor has, to send you, the results of my neuropsych testing, like when I have to do all of that, it just makes it harder on me, and it makes me feel like you do not trust me. And I feel as though we should have more trust as people with disabilities, that we're going to ask for what we need and it is going to be reasonable.
Just a little more trust, I think it would go a long way. And I think what you're describing, it's that almost this traumatic process of proving what you need in a context of such high stigma, where it, like you say, you don't want to be asking for it, yet I need it. And then the process is trauma inducing to ask for it and to be constantly questioned.
What I like to tell people, especially like my co-residents, is that I have to be smart enough to be a doctor, but dumb enough to need accommodations. It doesn't really make sense. And it is quite stigmatizing just asking for it. Honestly, like it makes you question everything, where it's like, well, do I actually need this? Or you're right, maybe my medication is enough. Like what? And you start questioning yourself about stuff where it's like, no, I know that I need this. I know it because this is what has been going on this my entire life. It makes you feel lesser than. And so I think that just, trusting that I'm going to send you correct documentation, and that I'm not asking for every other day off. you know, I'm asking for some extra time for paperwork.
Any last thoughts that you'd like to share with us?
I guess just going back to those who are interested in going in medicine, um, not only like embracing the disability, but making sure that you have your paperwork. It's it's annoying and it's upsetting, but it is very helpful to have your 504 plan from when you were in 8th grade, or having that IEP, or having that documentation from undergrad that you got accommodations for your exams. You may never use it, but it's a lot easier if you have your paper trail. If you have it, then keep it and make sure that it is in a safe space, because you never know when somebody is going to question it. And it's just like we said before, like nobody wants to be questioned, but it is a lot easier, especially for myself, where it's like, even though it was questioned, does Emily need this? It was a lot easier because I had all of my paperwork to just be like, yes, this is what I need, and here you go. Than trying to scramble. It's a lot easier to say, I'm going to ask for these things and maybe I don't need all of them, than to find out later, oh, no, I actually needed those and I shouldn't have burned my IEP afterwards because I was so glad to be done. Like, no, please, you know what, burn a copy of it, but like keep the original because you don't know. And it's okay. It does not make you lesser than to have this. It actually makes you better, because you have just much more of a wealth of information and of experiences. It'll make you a better doctor. There's no way that I could say that it doesn't make me a better doctor. It does. Even when I'm on consults, when I'm talking to people that do not have psychiatric issues but have high anxiety or other things like that, like I can assure you that it's helpful.
Yeah, having that historical archive, and if you can build that archive before you get to med school,
Mm-hmm.
digitize it,
Yes.
put it in all the safe places.
Yes. You have it on a backup server. I got it on my laptop. Like, and I can be very honest about it. I have a child with disabilities, and I make sure that I have all of his information because I know he's going to do some wonderful things. And I want to make sure it's going to be as easy as possible for him as well. And I talk to him about it all of the time. He knows what I have, just like I know what he has. And I like to remind him that his mother is a doctor with disabilities, and he's going to go so far because this does not define him. It's going to make him even better at whatever he wants to do.
Thank
Thank you, Doctors Jain and Green, for this incredible conversation about disability, self-advocacy, advocacy for others, and representation in medicine. To our audience, thank you so much for joining us. If you like what you hear, look for more episodes in our BIPOC 2 series coming later this summer. If you enjoyed this discussion, be sure to subscribe to our podcast, check out previous interviews, and tune in again next time. This episode is a continuation of our series on BIPOC individuals with disabilities in medicine. These episodes amplify the voices of healthcare providers at the intersection of disability and BIPOC identity, enlightening our understanding of the challenges for marginalized populations. By elevating these stories and sharing the lived experiences, we hope to advance critical conversations about race and disability and facilitate a greater understanding of the challenges and benefits at the intersections. Funding for this project was provided by the Robert Wood Johnson Foundation. Together, we believe that a culture of health requires the dismantling of structural racism and ableism so that everyone has the chance to live a healthy life. With additional support from the Stanford Medicine Alliance for Disability Inclusion and Equity and the University of Michigan Medical School Department of Family Medicine M-Disability Initiative. The opinions of this podcast do not necessarily reflect those of their hosts, the respective institutions, or the funders. This podcast is released under Creative Commons Attribution, Non-Commercial and Non-Derivative License. And this episode was produced by me, Lisa Meeks, with support from our editor, Jacob Feeman. Thanks, everyone, and have a great day.